They will be beaming, Robin, two cases simultaneously. One Ashok Seth from Delhi and Chris Naber from Apollo
Okay, now
Secunderabad.
injection, please.
And the plan is that we may go to Delhi first,
We are all
20
okay,
minutes
yeah?
of
So we
beaming
have flow.
from
Very good.
Delhi.
I would leave it now.
Then we go back to the second lab,
Yeah.
and then
Now
come
we
back
go
again for 7 minutes each, totally 55 minutes.
Right. Padman, are you connected?
Yeah, just a moment. We'll just get going.
I mean, at the same time, if you find something really interesting and if audience feel, panelists feel, then we can always switch on, switch over. And Bipan, you're ready for switch on, switch over any time?
8 or 10 millimeter balloon. 8 if you have.
Okay. Very good. Ashok, can you hear us?
Hi.
Yeah.
Yes, I can hear you very well. Can you hear me?
Very good. I think you all were eagerly waiting. You came from a space. And so welcome to the Earth in the space. And then let me introduce here.
Thank you.
Robin
Thank you. And
Chakravarti.
it's pleasure to be again. Sure.
Yeah. With me, I think Dr. Robin Chakravarti on my right-hand side, T.S. Clare. The name is familiar too, I believe. Next to him is Vijay
Right.
Bang, and then Dr. Singh
Yes, of
Chalu,
course,
Dr.
my
Rahman,
friends.
Dr. Ten, Dr.
Uh-huh.
Sharma. So we have people here eagerly waiting. Please tell us about your case.
Delta Azam. Okay. So what I have here is, and firstly, let me just introduce Dr. Vijay Kumar, my superb interventional cardiologist colleague. We have Dr. Babu and Dr. Gaurav, our very senior fellows, about to become consultants in interventional cardiology, both with us. So, Gaurav, why don't you present the case to them? Oh, you haven't got a mic? So Dr. Vijay will present the case.
Well, good morning, everybody. Today we have an interesting case where we would like to demonstrate multi-vessel PCI with the use of BVS scaffolds in a diabetic with triple vessel disease. So this is a 57 years gentleman who came to us with a recent worsening of angina from class 2 to class 3 in his past 5 to 6 months period. He had undergone a treadmill test also when he was class 2, having class 2 symptoms, and it was positive for reversible ischemia. His echo showed a normal LV systolic function, and the angiogram done electively revealed a triple vessel disease on the right and the left system, long diffuse lesions. Some of the vessels were small calibered, and the LAD was of a normal caliber. The syntax score was 20, and the MACE at 4 years, calculated MACE, is almost the same for CABG and PCI, standing at 28% and 28%. So the option of CABG and PCI were both there. And obviously, in this scenario, any patient would always prefer a non-surgical technique. And so he has been planned for an elective PCI. And we go ahead with the angio shots that we have
So
taken.
in the interest of time, and I know that you have 2 labs, let me just show you the angiogram. So can we switch to the angiogram, please? So we have here, you can see the left system, and it shows that it's got this OM, which is a long lesion in a, what looks like no more than a 2.5 millimeter vessel. There's an OM2, which is small, which is diffusely diseased. As you can see, we go to the next view. We have this multiple lesions in the LAD. As you can see, there's a distal lesion, which seems to be high grade. One may argue that that distal lesion may require an FFR. Then there's a high-grade lesion beyond the second diagonal. There is another high-grade lesion in the proximal LAD. And you can see that the LAD disease spreads close to up to the ostium. As you can see, there's a mid-segment looks like 3.5, but the proximal LAD looks like a 2.5. The mid-LAD looks like a 3. So there is disease process there. So there's bifurcations there. Next. You can see that again, multiple lesions in the LAD. Next. You can see the circumflex disease clearly out here at the bifurcation. Next. More views of what you can see, and I said describe that proximal LAD is diseased, and you can see the ostium is large, but the proximal LAD is diseased, and then there's a high-grade stenosis. Next. And then you have this RCA, which in its body looks fine, but then there's a high-grade stenosis in what is a very large PDA, which goes up to the apex of the heart. Next. Okay, so here's multivessel disease, mildly calcified lesions. Can we get this off? I don't know what's coming here. Can we get this off, and can we just get on to our angiogram, please? Okay, so now, again, in the interest of time, because you've got to shift between 2 labs, I just want to say that we didn't want to demonstrate a very complex case. We just wanted to demonstrate, I mean, you've seen enough complex cases, both from me and other great operators. But the real issue was that could we demonstrate how safely and effectively to use BVS in multivessel disease? And I think that is very important to understand. The technique is what dictates the success of the BVSs. And any concerns about BVS can be overcome by good technique. So really what we wanted to do was demonstrate to you its use in multivessels, small and big vessels, overlaps, high-pressure dills, and everything. So in the meantime, do you want to discuss anything, or should I go on, Ashwin?
Right, I think this is Robin. Ashok, what I was wondering that what is your strategy, and may I have some comments from the
Yes, Robin.
panelists? Dr. Tan, you can start.
Dr. Sengotil here. Just have one question. It's a very nice case with triple vessel disease. I could see that the PDA looks like less than 2.5, 2.25, and the OMs also a little smaller. So with the absorb 3 data showing not very encouraging result with smaller vessels, particularly less than 2.5. So do you have any concerns, or do you think the vessel size is around 2.5 or more?
Dr. Tan, can you have some comments from you?
Hi, Ashok, this is Wei Chim here.
So Sengatuvelu, great question, and I think this is a great question, and I would want to address that. This is, if anybody doesn't have a comment, I think Sengatuvelu's remarks are the most valid for such a case. Sengatuvelu, firstly, anything which you look visually as a 2.25 will invariably be a 2.5, even a 2.6 on an OCT. In fact, if you did a QCA, this would look like a much smaller vessel. So you know that as well as I do. So for me, if it's looking like a 2.25, it is actually a 2.5 millimeter vessel. Remember the second aspect of it. The absorb 3 had no systematic high pressure dilatations. I've myself shown the relevance of high pressure dilatations at OCT images and it becomes even more important in these smaller vessels. It becomes very important to actually make sure that you have adequately sized high-pressure dilatations, and most of these will end up at a 2.5 up to 20, 22 atmospheres of inflation. So actually, my personal data does not reflect the absorb 3 data, to tell you frankly. And I have loads of such patients. As you know, Indians have smaller vessels, diffuse disease, multi-vessel implants, and I've used it extensively in what visually may be a 2.25 to a 2.5 vessel. For the 2.5 visuals, I go up to 2.75. For the 2.25 visuals, I go up to a 2.5 full pressure dilatation. So just let me demonstrate to you what we do in these sort of situations.
Well,
So the crux is high pressure dil.
no, I think there is no question
Now-
that the
Yeah.
eyeball impression is
Go ahead.
always underestimating the size of the artery. That is everyday experience, that when you do eyeballing, I think you always underestimate. And
And in addition, Dr. Mehta, this is underfilled because proximal is such a very tight stenosis. The proper sort of sizing may not be appropriate. Can I have a comment from Dr. Tan?
no, but even
Hey,
proximal,
Ashok,
proximal
this is-
vessel also. Yeah.
There's only, and all these assessments should be after nitroglycerine.
Yeah, correct.
All these assessments should be after
Nitroglycerin
NTG
imaging will
intracoronary.
obviously change the sizing. Dr. Tan, can I have some quick comments from you?
Hi, Ashok. This is Tan Hui Chim here.
Yeah.
So this patient obviously has triple vessel
Alex
coronary
Tan, how
artery
are you? Great to see you. Great to hear from you.
Great to see you in action again. This patient has got triple vessel coronary artery disease, and to me, this patient will only benefit most from this LAD's lesions that is fairly diffuse. And I think there's reasons to use BRS here because this is a young patient. This is a very diffuse disease. If anything, with regard to BRS, this will be the ideal lesions to treat. But I probably will leave the RPDA as well as the circumflex alone and just concentrate on the LAD, given that this is going to be at least a procedure with 3 scaffolds perhaps, and the cost can be quite exorbitant here.
Dr. Rahman, Abdul Rahman?
Yes. Ashok, this is Abdul from Bangladesh.
Yeah, so-
Actually, this is a really difficult and tough case. I think so in surgery, regarding the RCA, surgery is not a good option for that. And I will not touch the RCA, but I will definitely touch to the LAD by BBS and maybe the LCX also, because OM is very big size vessel, OM1 or OM2 is a big, so I also would like to
Minus.
touch that also.
Right.
Just go to the
Could you
minus.
show us whatever you have done so far, Ashok?
Minus. So here the OM is fairly large, as you can see. The OM2, I would argue that can be left alone. It's diffusely diseased, but OM1 is large. Okay, so let me just show you, for interest of time, what we've done. And let's show you, okay. So that you don't waste time on your PDAs and OMs, can we just go forwards? And so here we go, next. And I would do this PDA. I mean, I think a BVS is a great option for this PDA. Next. And next. So we can keep showing, and then this is, so 7F guide, an all-star wire to provide good support for a distal high-grade stenosis. Next. A 2.25 balloon, and I always say near optimal size balloon to high pressure dilatation. There's a 2.25 to 22 atmospheres. Okay, so dilated adequately. Next. Next. A 2.5 millimeter scaffold over an all-star wire, positioning it accurately. There's a distal landing zone which has to be respected very carefully. It is a small vessel. We have to respect that distal landing zone. You can see how I respect it. I'm absolutely accurate. Next. Next, next. So dilatation as usual, and then going back with a 2.5 balloon. Next. And positioning it accurately. Next. And going up to 22 to 24 atmospheres into this vessel. Next.
So
Next.
are you using any imaging to guide
Next.
you?
And next. Yeah. No. And I again can actually say very, very clearly, next, that if you get results like this with a 24 atmosphere inflation, with a step in and step down, here it is. Next. And this is the final result, minus. If you get a result like this, which is bigger than the rest of the vessel, I don't see any role of imaging, is going to tell you, it's not going to tell you to go up any higher on this vessel.
Ashok, in 4 minutes
so I'm
time, we
pretty
are going to switch over to the other
about
lab.
results like this. And next, yeah. So I'm going to go on to showing you that this is a 2.5 now of what was a 2.25 millimeter vessel.
Yeah, perfect.
I'm confident about no imaging in Satni. This is what I said. Let's. So,
Can you go to the next?
just go minus. I'll just show you the final result, which is this. Next. Okay, let's go to the next. I said, because I wanted to show you the LAD, I said I'll do the OM in the meantime. And again, a 2.25. Next. Yeah.
Ashok,
Yep.
this is clear here.
Next.
Can I comment?
And here it is. Yeah, clear?
You know, if you see
Yes, go ahead, comment.
If you see the right
Next.
coronary artery, the PDA distal to the stent, it's hardly a vessel actually. I really don't think it was worthwhile to do the right coronary artery. I mean, that's my view at least. There's very small artery left
It
beyond
goes to the
stenosis.
apex, Claire. Yeah, it goes to the apex. It could be argued either way. I'm not a proponent who's going to fight the battle on this issue. It's a personal opinion on these issues. Yes, it could be left. I don't think the patient would suffer greatly. I just felt that it was going around the apex and therefore might as well do it and give him the BVS and have a complete revascularization. I mean, there was an argument by
Ashok,
Hoichim that OM could be left alone as well. Again, I'm not arguing about it.
no, I think if the surgeon was to handle this case, he would have bypassed it, so you should have done it. And you did it. I agree with you.
Any disease in the left main, sir?
So I have dilated this OM again with a 2.25 to extreme high pressures of 22 atmospheres. I positioned a 28 into minus, go minus. Yeah, next. And this is again at high pressure dilated. Next, and a 2.5 into 28 millimeter scaffold has been implanted into this OM. And I'm just going to now do a post-dilatation. So by the time you come back, I will start showing you the LAD also.
Right. So have you sort of done anything on LAD? Meanwhile, can we get connected with the other center?
Yeah, you get connected. I will cross into the LAD after the post-dilatation of this OM, which I will do with a 2.5 balloon at 22 to 24 atmospheres, and I will go into the LAD.
Right. Before you switch over, a quick comment. Did you do imaging of the OM territory or just did like the RCA? I think we got disconnected. Can you connect us with the other hospital?
So meanwhile, I think
And some comments.
question is that I think the Ashok's attempt at a total...
To understand,
All right, is he still there or?
No.
Ashok?
Can you have some comments from the panelists about this?
I think is an issue is of
PDA.
Yes, Madhikar?
Still here?
About the PDA, we are discussing BVS or not, but I think it's a reasonable size PDA which you need to stent. Whether BVS is the right option or not, that could be
I
debated.
think, Madhikar, we can take an attitude like this, that if you have a reasonably easy and straightforward opportunity to revascularize any ischemic area whatsoever, like how effectively you can do a total revascularization and can be comparable. Like I would have believed that if this case was to be handed over to surgeon, he would have definitely bypassed a PDA. And therefore, I think it may be a reasonable approach to do this. I would say so. Okay, now...
I think we are getting connected. Hello?
So as compared to Delhi presentation, this is mild, sober, and polite, and yeah? The usual cultural differences. Okay. All right.
Hello, Dr. Naber, Dr. Shiva Kumar. Hello, can you hear us?
Yeah, we can hear you very, very low voice, nearly nothing.
So he heard you, but he would
Voice
not
is
reply
low.
otherwise.
Yeah, we are
Anyway.
hearing at very low volume as well.
Yeah, okay. Hello, Chris.
Yes, hello.
This is Ashwin Mehta. To me, next to me is Robin Chakrabarti, and then T.S. Clare, Dr. Vijay Bang, then I think Dr. Singit Valu, and Dr. Ten from, Dr. Ten you know very well, from Singapore, and then Dr. Madikar, Dr. Rehman, and there's a big orchestra here.
Yeah, so it's many friends. Hello, it's very good to be here. Thank you very much for the invitation. We are here in Apollo Hospital. I'm here with Shalup and the entire team from Apollo Hospital, and we have a quite very interesting case, I believe. And I think Shalup will take you straight into the case, and then we can discuss.
Oh, I can't clearly hear you. Can you hear it?
Hello everyone, I'm Shalup here.
Can the audio
Voice
be
is not
improved?
clear.
We can hear you.
On the other side, we cannot hear it clearly.
Yeah.
Okay.
Meanwhile,
hear?
can you so tell us the story of the patient?
Yes, we will.
This is a, next slide, just go. This is a 58-year-old male. He's a known hypertensive and smoker, not a known diabetic. He had a history of TIA 6 years back, now presented to us with grade 2 angina. His vitals are stable, blood pressure is around 160/90. Next slide. This is the ECG. You can see fairly not much STT changes. Echo. Echo, there is a mild hypokinesia of LV apex and basal IVS, otherwise adequate LV systolic function. So his angio is,
We have the angio. So the previous angio showed the distal left main 60%, 80% bifurcation lesion involving the ostial circumflex, and he has also a trifurcation lesion distally, and the RCA has also stenosis.
a 90% lesion,
RCA has also 90% lesion.
which we are planning to do it.
And they are planning to do it this stage. Now let's go to the angio images that we have here. Syntax score is 22. Can I see the angio? Okay. Now here you see our first angio image. You can see that there's a lot of plaque in the distal left main and also heavily diseased circumflex, quite long lesion, let's say at least 10, 15 millimeters into the circumflex. But what you can appreciate that there is also, here you can nicely see the plaque in the distal left main and the diseased circumflex. Can I have the next, please? But here you see, leave this here. This is the trifurcation lesion of the LAD further down. It's very, very tight. We have two diagonals arising from there, and then a quite big LAD coming from there. And you can see also some calcium if you look closely. So our target is today the full left coronary artery. We will not treat the right today. This will be done later on. And the question is now on the strategy. And if you want, I can take you into your strategy, into our strategy, or you can have a short discussion, whatever you like.
Right. So can you have some comments from the panelists? Meanwhile, for the audience, did you see?
Right coronary?
Right coronary, yes. Right coronary, please.
What about right coronary?
Yeah, I didn't see the image here, but the right has in the mid portion has a high degree stenosis, which will be treated later on.
Okay. Did you see that both the cases have a syntax score of 22? So it is a 22. Today is 15th, by the way. Can you have some comments from the panelists?
Hi, Chris.
This patient is a diabetic and a triple vessel disease.
He's not a diabetic, sir.
It's
not a diabetic.
okay. It's a left main disease, then there is a trifurcation of the LAD, and I am told that there is a tight lesion in the right coronary artery. I would personally think that in a country like India, because of the cost involvement, I think surgery would be a better option. Anyhow, I can see the vessels are not calcified. I think it's a very doable case. It's very nice and challenging case, and I would love to see the outcome.
Okay, maybe I can comment quickly on that before we show you the steps and explain the strategy, because we need to proceed. So we talked to the patient, at least not me, but the colleagues here talked to the patient in length, and he's quite not keen on surgery. That was discussed with the family back and forth, and obviously I cannot comment on that. The decision was that they would like to undergo PCI. I discussed the same with the colleagues. I also see an option for surgery, but we also believe it's doable, despite it can be quite challenging. So maybe let me take you through what we did so far and then talk about our strategy. Our first strategy was to treat the LAD lesion first. And here you see we are entering the LAD with a fielder wire. We wanted to also wire the diagonal branch. Here you can see the wire on the diagonal branch. And then we said, depending on whatever happens, we would like to dilate. And you can see that even a 2.5 balloon doesn't cross the LAD lesion. Next.
It was a 2 balloon.
It was a, no, 2.5. And now, it was a 2.0?
2.
Okay, now 1.5 crosses. Next, please. Patient has chest pain, which is expected. We are dilating several times. Here again, you see it does not fully open.
This is a single, what balloon is this? How much? 1.5?
1.5.
This is 1.5. Yeah, you can see from the middle marker. It's a 1.5 mini
1.5, definitely.
Yeah, next.
The balloon is sleeping.
Yeah, patient is having chest pain. He's quite anxious. Here you see the first result. And yeah, next. And now we take a bigger balloon because we couldn't cross with a stent. Our plan was to take a 2.5 stent and to make it then afterwards a little bit bigger. So this is a 2.5 balloon. We took it to quite high pressures, and we are dilating several times here. Okay. Next, please. You see the fielder always comes out. Now, this is 28 2.5, because we thought it's a drug eluting. It's a science alpine. And next, please. Next, please. Our plan was to bring it a little bit further down. So here, this is a good implantation position because we're covering the full disease segment. And now we took it up to 2.5, 27, and we took it up to 16 atmospheres. And you can see that we have quite some challenge here in the proximal part with the calcium. Next, please. Here you see it's nicely expanded now. Next, please. Next, please. So this is our first injection. We have good flow in the diagonal. Our plan was to keep the diagonal simple because we still need to treat the left main. Next, please. Now what we did was we took a short 3.0, I think 15 or 10? 8. 8, oh, it's 8. And we took it up to do a pot. Here you see the pot. Next. Now it's better expanded here, but still not fully. And then we dilated the tighter part. Next, please. You can see the same here, also not fully, but better expanded. And you see quite a good result. Next, please. Now we took back the wire and pushed it down. Again, it's a BMW now in the LAD. Next, please. Next. Okay, these are thought to be our final shots on this. One, and the next in the spider. And here you see that we still have a big proportion of calcium. So we decided to go with very high pressure with the 3.5 balloon again.
3.30.
3.0, sorry. Next, please. Next, please. Next, please. Yeah, here you can see we are going up to 22, 24 atmospheres. Next, please. Okay. We believe at the moment this is the best we can get. We have some impingement of the diagonal, but it's not too big. We have quite a good flow. We would like to leave it now because manipulating too much in this big plaque in the circumflex ostium and the distal left main could cause some problems. And we would like to proceed now with the left main.
I think you got getting
very good, but Claire, I think both the cases had a syntax score very similar. And yet I think this particular one is more demanding than the other one.
No doubt.
Yeah, so that was the syntax score can translate your ability to do the cases comfortably is not true. Like, it is different. Like,
See, the thing
like
is-
you rightly said, that you will not be, you will be happy to send him to
Go on the
surgery
spider,
also
go on the
in case
spider,
of the
go on the
overall
spider.
circumstances demand. I
Spider,
totally agree with you.
2.520
I
balloon.
totally agree with you, and I think even
2.520.
electively also, somebody who does not want to take a stress of a complexity of this case can also think of sending the patient to surgery also.
No, it's not a question of taking the stress. It's a question of even the long-term results in a patient.
Yeah.
You know, this is a trifurcation of LAD, then
2.520
there's the left
balloon.
main disease, then the circumflex is arising 90 degree.
Yeah.
And there is a at least 15% chance that he will develop stenosis of the circumflex ostium after
Yeah.
the stenting.
True.
We know that, we have the experience. So this patient, certainly my choice will be surgery. But the previous case, Dr. Seth's patient, I will prefer angioplasty. Why? Because LAD is diffusely disease. There are 3 lesions. There is the proximal, there is mid, there is distal lesion. I don't know whether the surgeon will be able to do revascularize all the 3 segments or not. They'll put a Lima graft at one place. So in that patient, I think BVS with the PCI is a better option.
Right,
Agreed.
but I think since we
Sigarveru?
have taken,
No, I agree with Dr.
Yeah,
Vijay's view.
yeah. I think it's just important for us to understand.
So,
Just
Christoph,
merely
I,
somebody tells you a syntax score,
Yeah,
does
doesn't
not
mean-
tell you everything about the case.
especially the long-term results.
Yes.
But now they have decided to do it sort of by intervention. Any comments about taking an imaging technique?
No, in this case, with Dr. Naber's case, I think when he's doing left main, I think intravascular ultrasound will be helpful, and
Take it
particularly the calcified lesion, and he had difficulty in getting the balloon. So maybe if pre-procedure IOS would have given us a lot of information, maybe
Exactly.
a rotation may help us.
I think so.
810.
Yeah.
In any case, one always leans towards doing imaging when you are handling distal left main.
Go down.
So you
Dr.
like-
Madikar, Dr. Tan, Dr. Rahman, any comments?
Hi, Christoph, this is Hui Chim here. So
Hey,
I,
Hui Chim.
I agree with your strategy of a provisional stent approach for the LAD and diagonal, and but probably you will need a 2 stents for the distal left main stenosis. My question here is, would you consider some kind of IVUS guidance here to help you with sizing and positioning and so forth?
So,
Dr. Rahman, what is
Yes,
you're thinking about
so,
taking the patient for bypass surgery?
Actually, I will go for the
injection.
provisional strategy from the left main to the LCX. Then I look for the LAD ostium, and by IVAS and FFR, if it is needed, then I will
Okay,
finish by
now
the
give me-
tap technique.
But
Now-
in addition, I think Dr. Clare's
give
point
you
is
the
quite
stent.
valid. Can you sort of have a little more discussion about,
yeah,
can you have some comments on this,
go with
Dr. Kale, and
You want to ask the panel before?
having bypass surgery?
Pardon? Regarding?
Dr. Clare has made a comment that this is a really complex, having all the 22 score.
But of course, if you go by the recommendations of all our associations whom we believe a lot, bypass surgery is the first choice. But if the patient has decided an intervention and this can be today done so easily and effectively, I think that's a fair enough option. May not be the number 1 option. Having said that, for me, left main still remains imaging technique related intervention. I would love to know from Dr. Naber and from the members here present, the senior members, whether they now consider that intervention, the imaging is an optional event for left main or it is a must.
Dr. Madeka, then Dr. Vijay, any comment?
What?
I think in this patient we have first again discussed bypass versus angioplasty. You need to have some compelling reason to go ahead and do angioplasty
give
with
me
multivessel stenting. We are underestimating a little bit of risk of restenosis over a period of time, not only in the first year.
I think it's good,
Over
huh?
a period of time. So if you look at long-term
Go ahead.
disease-free survival,
Okay, go okay.
definitely bypass is good. But when you do such kind of techniques, would you like to consider rota first to have better apposition of stents
Well,
because
that's important. Go
that's
up
the
to
most
16.
important point which may decide the long-term survival of the stents in this patient.
And
16?
yeah. We can see now there is a stent
Go
is
down.
being placed at the left main right down to the circumflex. Dr. Tan, can you have a comment about this stent? Did you see that stent is going from left main to circumflex? So we know that, the angulation of the left main to circumflex, when you put a stent, there are some issues about in-stent restenosis, further maze. Any comment on that from the literature?
So I think the best way to ensure the best long-term outcome results for
Rajyo.
osteosurgery is to get
And
the
the
best
balloon, the big
MLA
balloon?
that you can proceed
no, big balloon.
procedurally. So
4.5,
that's
no?
why I say
You want
IVUS is very
4.5?
helpful
4.5
here.
balloon.
4.5.
Right now, there seems to be already a waste in the
4.5
ostium. I would use IVUS to guide my
4.58.
post-deal inflation here. But looking at the way Christoph is doing it, looks like he might be going for a keloid stent strategy.
So maybe I can just quickly comment. The point is the following. We can take an IVUS before for sizing. We know where the plaque is. We can do all that. At the end, the stents from 3-0 onwards. Maybe you can, I can look to the people. So we'll
take one shot. We have not taken a shot.
Are you planning to culate in this case?
Just a quick shot. Okay. Go. Quick shot. Okay, it's all fine. Yeah. So maybe I can just look. So the point is the stents from 3.0 onwards are all the same. They are just mounted on different balloons. So I need to size my stent to the distal vessel. Here we have a big discrepancy between the left main and the circumflex. So I will take a stent that fits the circumflex, and then I can take it up to 4.5 or 5. And I agree with Hua Chim that if I'm not sure if I can remove the waist fully or whatsoever, I will need IVUS guidance maybe at the end to have a look. At the moment, I will now take a 4.5 balloon and do a pot in the left main and see how we come out. And then I would like to reopen to the LAD, and then we see. This is now my 4.5 balloon here, which goes in.
This is Dr. Bang. I would like to ask you, looking at the ostium after the stenting of the circumflex particularly, I think cutting balloon or some sort of angiosculpt should have been used before stenting this. Because it looks like it has not opened up. Now, this will produce more restenosis chances in long term.
Okay, is this a non-compliant balloon? So I'm quite happy with your comment. Unfortunately, I don't know if a cutting balloon would really bring a better result. We talk about that, but we never show it. Can I just quickly see the position of the balloon?
Right, you got 4 minutes time. By the time we just switch over to the other lab.
A bit. Yeah, which is fine. Just inject.
Christoph,
I think we're good here.
Christoph,
go up.
Maybe tap.
Christoph, this is Hui Chim here again.
Hi, Hui Chim.
The osteocircumflex stent appears to be probably a little bit under-deployed here.
Right.
Sometimes I will, if you don't, I would actually optimize the ostium circumflex first.
I'm doing
in addition to the ports, because once you put in a stent through the stent struts into the LAD, I have seen cases where the osteocircumflex now becomes collapsed and very difficult to go through.
Which I fully agree. And you could see maybe from our attempt to do the pot that the balloon moved out backwards. So,
sorry, but what size of balloon was this?
That was a 4.5 for the pot. But it moved out backwards. You can see nicely here. So I agree with Hua Chim. That is a good suggestion. We will do first optimize the ostium with the 3.5 NC balloon and go just straight over the ostium and make it as big as possible, and then go again with our pot and then rewire the LED. So when you come back next time, we most likely will have
you got another 2 minutes if you could continue.
Okay, wonderful.
What is your plan? Is it going to be culate or going to be plan a tap?
My plan would be one stent, if it's possible, because there's not much disease in the LAD.
One stent. Sorry, I didn't hear. What your plan is?
One stent, if possible.
One stent?
One stent. So you leave LAD. Any comments from the panelists that,
Yeah, I think
planning to leave LAD completely unattended?
If you go from left main to circumflex stenting and leave the ostium of the LAD as it is without any stent, then chances of this coming back is even higher.
The IVUS study tells us that 90% of distal left main has got some kind of osteo-LAD involvement here.
Yeah, we can see then.
We will take a picture and see, but the ostium LAD is already looking not normal after the stent.
I think there is a great paper published in European Heart Journal by Dr. Fajad's team, and they have shown that if you just do a circumflex and with angulation, the long-term outcome is not good. The chances of having MACE, instant restenosis is phenomenally high as compared to if you just leave LAD completely unattended. Meanwhile, can you switch over to Dr. Shed's lab?
Ashwin, I think for this case particularly, planning this study, I think IVUS is a must.
Absolutely.
Okay.
This case.
Okay, apart from that, in general, to make LAD as a side branch, that idea is not comfortable to me.
Well, this is...
you can't make LAD as a side branch. It may be smaller compared to it. It's a type 1 LAD.
Meanwhile, can you switch over to Dr. Shed's lab?
We must remember that the septal contribution to an ejection fraction in the free anterior wall is, if you see a regional ejection fraction of the apex is 85%. So I mean, LED is to me is the most important.
Correct, absolutely. And Dr. Mehta,
I
you look
agree
at
with
this.
you, I agree with
Now, there is
particularly when it
residual
is
narrowing.
disease,
Still in the
there's
distal
already
left.
a stain there inside in the LED
Okay.
at the bifurcation.
Yeah.
No, I may accept LED being the side branch only if the LED is short, as you said rightly.
Short, correct.
Secondly, the proximal diameter is around 3.5 millimeters. Because even if it's a little bit pinching, still there is a lot of lumen left. But in this patient here, it to me looks very uncomfortable to leave the
This
LED.
is a big, Dr. Clay, this is a big LED.
Go up.
You've got a branches, diagonal, septal, big LED. It's a big LED.
Dr.
Mehta, will you
Naber,
contribute
Dr.
this?
Naber. Yeah, sure.
Timer on.
Will you call this as a
EDS would
sensible
have been a better
incomplete revascularization?
EDS would have been a better strategy.
MS, midazolam, please.
Do you call this a sensible incomplete revascularization?
6.
Sensible what?
Sensible incomplete revascularization.
7.
You left the
It's
diagonal.
like, you know, I want to tell you, your question
Give me the 2.25
reminds me,
and see.
Shatrughan Sinha
Am I
was
back
asked
live?
once. Listen, this is interesting.
Am I
Shatrughan
back?
Sinha was asked once.
I
"Are
can't
you
see
happily
myself.
married?"
Can you see
So
myself?
there's nothing like happily married. Are you happy
Hello?
or married? So there's
Yeah,
nothing like sensible
but I
incomplete
don't know.
revascularization, like deliberate
Yes, we are already.
incomplete
Dr. Shet?
revascularization.
Dr.
Anyway,
Shet.
Give him sedation, please.
Dr. Shet, we are back.
No, he should not feel anything. Deflate. Okay, I'm happy to be back. So let me just show you what we've done in the meantime. And I think it's very important. So let us, I can hear you. Can you hear me?
Yes, we can hear you. Go ahead.
Can you hear me?
Yes, we can hear you very clearly.
Okay, so I'm saying let me go
don't see
back
anything. We
to
can't see
what
anything.
we've done. And yeah, let me go back to what we've done. They don't have the visuals. They don't have the visuals.
No, we can see you.
we
can see
have
you clearly.
we have now.
Do you have the visuals anymore?
Yeah.
Yes, can see you.
Now, do you see the angiogram?
Yes, we do see the angiogram.
Oh, no, can you see the angiogram?
Yes.
Yes, Ashok, we can see now.
Okay, so let me take you back. When we left the OM. Yes, I've understood. So let's go backwards to the OM.
I think
OM.
love more to discuss about LED strategy, Ashok.
OM.
Because that's the most important and a complex.
No, you need to see something about the OM.
We don't want to miss that.
Hang on. You need to see something more about the OM.
Sure.
And I think I'm here. Sure. No, I'm here to tell you certain things which are important and not for you to see a show. So please understand why I'm showing you this.
Sure.
Okay, now the important thing to understand is the issue which was raised by Senga Tuvelu, by Chim, are you going to image this? And I said I won't image it because I know that if I follow my dogma of larger size balloon and high pressure post-DIL, I get adequate results. But just to demonstrate that, and the same thing I wrote up in the Eurointervention journal, is the single imaging fact that this vessel, after implantation of a 2.5 scaffold, was dilated with a 2.5 to 24 atmospheres distally, and then a 2.75 to 20 atmospheres. Now, the reason I say 2.75 is that if this visually looks to you as 2.5, then I would invariably dilate it with a 2.75 to 20 atmospheres. And what do I get on my OCT, which I did? And I wasn't going to do an OCT because I know what it would show, but I did it for you all so that you can see what it shows. And look what a 2.75 at 22 atmospheres does in that vessel. It actually does that. It actually makes it a 2.5 millimeter internally. And look at the struts. So 3 things I wrote up in that editorial and gave the OCT images. It actually enlarges the lumen further. It does away with any undilatable areas, despite the fact that you think that this is a 2.5, and it embeds the struts into the vessel wall. And can you just run that OCT? Is OCT connected?
Yeah, we can see the OCT image.
Can you run the OCT? No, I want the proximal part of it. I want the proximal part from where it is. Okay, can we just move away? No, further go distally. And now run it backwards. And you will see that the embedding of the struts, look at the way the struts are embedded into the intima. they almost, at some stages, start looking almost endothelialized into the vessel wall. That was the branch which you saw there.
Sure, yeah.
So what we have at the moment is a 2.75 dilated vessel. And you can see that you'll start seeing the embedded here. Can you see that?
Yes,
That
sir.
is what, so I don't even need to do an OCT to do something like this. I know I've got to go up with a 2.75. So that is where I say post-dilate with a quarter-size higher balloon. Even when you have a perfect result, if you saw the 2.5, it was a perfect result. Go back one image to this. No, not the OCT, angio. Angio, this is the 2.75 balloon. Go minus, 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 minus. This is 2.75. Okay, this is after a 2.5, and you would have said this was great.
Ashok,
Okay. So now let's do the LED now.
Ashok,
So
Ashok,
the
Vijay
lesson
here.
is-
Ashok, Vijay here. Vijay Bang.
Yeah, Vijay.
Yeah, Ashok, I think it's great
Yes,
result.
Vijay.
I could see the boxes on the OCT very well.
Give me a 2.5.
I appreciate this.
Yep.
Right, we could see the OEM, and
Okay,
after
so
that,
now
what did you
here
do?
is the LED all of you wanted to discuss.
Yeah. You just show us the LED
Okay, so
part.
LED, let's go to the LED now. So LED has been wired here with an all-star. I have an extensive job. No, I want a 2.5. So you can see that there are lesions. We can either do proximal and then do a FFR to the distal lesion, or pre-decide that everything needs to be treated anyway. And if everything needs to be treated as I decided, then I started looking at the distal lesion, and I said, is there a place that I can actually just do the distal lesion separately and then do the proximal all together? Is there a space for 3 different scaffolds for each of the 3 lesions? And finally, after post-dilatation, and I'd used angiosculpt, by the way, and it's a great balloon for smaller vessels, which should have been also used on the OM. Next is that I finally, when I dilated all the 3 lesions with an angiosculpt, 2.5 millimeter angiosculpt, I started realizing, next. Firstly, it was pre-dilatation, and then there was angiosculpt. Next. This is angiosculpt at 14 atmospheres. Next. So you can start seeing that there's no way that you can do a good job if you start putting 3 separate scaffolds. The mid lesion practically merges into the distal lesion now. And so it's better to make sure that you just scaffold the whole of the vessel from the proximal, maybe distal, maybe the proximal could be a separate one, but certainly all the distal and mid should become a part of a single coverage. Next. Okay, this is the angiosculpt. Next. Okay, so we can go away the angiosculpt, high pressures, 17 atmospheres with the angiosculpt. And so now this is the first scaffold gone in.
And what length is it?
You can see that that's not fully, that area of the lesion did not have a complete dilatation. This is 28 millimeters, 2.5 into 28.
Right.
And this is where we are. Now, you will see me actually going in, and certainly at this, let me see
so we'll
how
be disconnected.
it
We'll be
responds to a
disconnected soon. We are
2.5
going to the other lab now, and
I may
we've got
actually
final
subsequently-
minutes where, meanwhile, you continue the case.
Okay,
Can
you
switch
go
over to
ahead.
the other lab,
By the
please?
time you come back, you will see.
Sure.
You will see. Correct. You'll see my high pressure dilatations.
Will not come back.
Go up 2, 4, 6,
Ashok,
8, 10, 12, 14, 16, 18, 20,
Ashok,
21.
let me tell you that we are not going to come back.
Yeah.
Whatever you want to say.
Bye-bye.
He's not here.
Okay.
I think whatever you have done is a great
Great thing.
elegant demonstration of the usage of DRS in a very complex
So I
coronary
will
artery disease.
actually completely cover this vessel. Yeah. And it'll be end-to-end, by the way. I won't overlap it in smaller vessels. I'll put it end-to-end. I'll do OCT at the end of the day for this vessel because it's going to be a complete stent scaffold coverage of this vessel. And I will definitely do an OCT on this vessel because I feel it's important in this vessel and not the other vessels as you were discussing.
Excellent. Can you have a big hand for Dr. Sheth?
Yeah.
Thank you. Wonderful demonstration, and congratulations for showing a good case. Can you move to the Secunderabad lab, please?
Thank you.
Thank you very much. Thank you for a great team efforts.
You move this to AP cranial.
Hello, can you see us?
AP cranial.
Yeah.
Okay, what we will show us please the result immediately after stenting.
Show that.
Go for EDS.
Can we show it?
Elective
Okay.
stenting.
No, please go to the result after stenting. After stenting.
After standing.
Yeah.
Previous. Yeah.
No, yeah.
Yeah.
And
From
now
there you
next.
can start.
Okay, from here we start. Just keep it there. We will do the rest now live.
Then
Okay. Now what you see here is, as you see, the implantation of a 3-0 very long stent in the circumflex and the left main, and some people started talking about sensible, incomplete revascularization or something. So let me show you the next. Next, please. So this was a balloon 3.5. No, that was our attempt to do a pot with the 4.5. Next, please. Now this was a 3.0. Next, please. 3.5, but you still see the edge. Next, please. And now again, it doesn't work. Next, please.
Calcium.
Okay, now we still have the edge. And now what you see here is, again, the 3.5 at 24 atmospheres. And you can see that the waist is gone. Yeah? And you see now a very nice result here in the proximal circumflex, and you see some impingement of the LED. We will see if it will be enough to just do one stent technique. If it's not enough, which I can imagine from this image, we will do a tap technique. So where we are at the moment, so the waist is gone. I think there are no concerns about that anymore. And what you see here is we rewired the complete thing. Can you now please go back to the caudal? And we placed a 3-0 balloon in the LAD, and for the sake of time, I'm speeding up a little bit things. So I don't wanna wait too long with just dilating one side and the other. So what I'm trying now is to do an immediate kissing. What I'm doing here is pushing a 3.5 balloon in the circumflex, and then we have altogether 6.5, which should resemble about 4.3 or 4.2 millimeters of kissing balloon technique. So now we are quite okay, and we will now start with the kissing balloon. The important thing is that we drop the pressure in the circumflex last. So who has the circumflex? You have it, okay? Yeah. Okay, please go up with both balloons. Go to 10, go to 12. Both balloons
go to 10.
Go.
10. Both balloons 10.
10.
Both.
Go. Okay,
Yeah.
very nice. Okay, now you go down first. Okay, and now we go down with the circumflex.
Yeah, go down.
Okay, fine. So at least we opened, and now we can see if we would like to take a stent in the LED as well. Let me remove them and do a shot here, that you see something to discuss.
Yeah, shot.
Injection. Okay, can you inject? Okay, thank you very much. Looks quite good.
Looks better.
The question is if we need to stent the proximal LED, which had not much disease. And for this, I would like to take an IBUS and have a look on the ostium of the LED now.
Yeah.
Dr. Naber, I had a question. In your routine practice, do you do these left mains without imaging?
You should stent because
you always do imaging.
No. I use imaging if I have a question which I can clarify. I never use imaging without a clear question that I have. And here I now have the question, should I stent the LAD ostium? So because you were citing Dr. Fajade, I was working with him for some time.
What is the percentage of time that you have a question to be answered with imaging?
Well, let's say, I would say maybe in 30% of cases, I would like to take a look.
LED where? Which is the LED where?
Let me see, I check that.
Hi, Christoph, this is Hui Chim here again.
Yeah.
I'm just feeling here that with or without the IVUS right now, it is going to be hard to leave the ostium of the LAD alone. If you look at the LAD, ostium is much smaller than the distal.
Could be, yes.
Distal diameter, and that now that you have balloon angioplasty, the ostium of LAD, some kind of trauma may have already occurred, and this may be a spot for restenosis, which is a bad spot. So I would err on the side of caution and just go ahead with stent.
I agree with you, Hui Chim. Most likely we will end up like this, but because we discussed it, I would like to take a look and see now, and then we can, we don't need to discuss. I believe also I will end up putting a short 3.5 stent in the LAD, which would then end up as being a TAP, which is a good procedure. Finally, 2 stents, which is then okay. But we made the attempt of having 1 stent. If this is not possible, we go with 2, which is absolutely no problem. I mean, you can go with 2 without any doubt. Let's have a look how it looks in the IVUS. So we have the IVUS probe here. And maybe we take a 3.5, 10 or something stent. Yeah, 12, 10. 3, 10.
If you could show us quickly in 1 minute time, you will be disconnected.
3.5, 12 we have. Yeah.
If I can make it.
What size of stents is taking?
What size is it? What size you are taking now?
This is now an IVUS, but I would take a 3.5. For the LAD, I would take a 3.5.
3.5. Length?
Length short.
12.
I believe it's 12 maximum.
12.
But we will see with the IVUS now.
We have an 8 also, but I think we'll require 12.
But for this question, I think the IVUS is then helpful, and we can tell after the IVUS.
No pile
So can we go in?
worry.
So we could easily end up with a TAP,
No.
which is for me absolutely fine, which is good. Are we okay? Okay.
Okay. Go ahead.
Absolutely.
I would.
So it's a good demonstration of the case. We are going to be disconnected in a minute.
Yeah, I tried to show you the proximal.
It's 3.5.
You see the IVUS, yeah?
Yeah, we are seeing.
3.5 to 4 almost.
A lot of plaque.
This, there's a lot of plaque. We will take at least a 3.5, maybe even 1, 2, 3, 4. It's 4. I would take a 4.
It's nearly 4.
After IVUS, I would take a 4. So my strategy would be, can you pull back that we
some calcium as
see
well.
the stent?
7 o'clock, 8 o'clock.
Yeah, right. I see the same.
Spotty calcium.
Yeah, I pull back manually. Yeah, here and here. This is very nice. Here you see, it's heavily diseased in the ostium. And now I pull back, and here this is our left main. We have quite good apposition here. You see, this looks nice. But so my strategy is clear. After the IVUS, I will do a 4.0 12 millimeter a stent for the LAD. Then I will do kissing again, and I will finish with a 4.5 port.
You have?
I will finish with a 4.5 port. So if you want to disconnect, this is my strategy. You want to see a final shot, how we look at the moment?
Very nice. What do you think, Dr. Mehta? How was the case? You could conclude the session?
Inject.
I think we just...
Sengu got a quick comment.
To make a comment.
Yeah, okay.
Go ahead.
Okay, 4.5.
Retrospectively, what I would like to,
12.
I feel in this case is one, if you had done an IVUS pre-procedure,
Yeah.
we would have clearly known that there's a lot of osteal disease, and we would have pre-dilated the distal left main adequately, because he had a lot of difficulty in post-dilating after the stent implantation. And then definitely it would have been a 2-stent strategy. The first stent from left main to circumflex, I have a lot of concern in putting a stent into the circumflex.
Correct, agreed.
Unless you do a QLOT, it's better to put the first stent into the circumflex. So if he's planning a TAP or any other 2
Do LAD first.
Yeah, it would have been
that we discussed.
LAD, or if it's a DK crush, we can do the circ first also.
Correct.
If you had not done the imaging IVUS before, it would have been a clear 2-stent strategy, and you could have planned appropriately to plan the first stent into the LAD, or a mini crush with the first stent in the circumflex.
Agreed.
The second is basing.
I think it is very good comment. Number one, let us do, all the data, Nordic 1, Nordic 2, Nordic 3, and Nordic 4, that even a provisional stenting is good enough for a large size side branch, Nordic 4. Now I want to tell you, I can take the fact the other way, that the provisional stenting can produce as good a result in terms of MACE as 2-stent strategy. If that is so, then in that situation, I could take it the other way. You don't have to worry about increased MACE when you use a 2-stent strategy also. That means do not hesitate or don't be too intimidated when you want to use a 2-stent strategy, because the complications are same as provisional. I can take the factor the other way also. So I think whenever it is necessary, if your gut feeling or your mind or Your interpretation tells that you should go ahead with the two-stent strategy right from go.
Dr. Ashwin, I know it's an off-level indication, but I think the left main or bifurcation lesions, I feel it should be a good idea to use bioabsorb after preparing the bed very nicely, because, I don't like the idea of too much of metal in the left main forever in the life of a person.
There is no data.
I think thank you very much. Thank you to all the expert panelists, colleagues, and Dr. Mehta.